So I'd just like to begin by acknowledging that the Women's Health Research Institute are uninvited guests on the unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh Nations. And as a provincial research institute committed to improving the health outcomes of women, including those across the 2SL GBTQIA plus spectrum, we recognize our responsibility in the collective efforts towards establishing culturally safe healthcare systems and services that address health inequities among Indigenous peoples, especially Indigenous women, girls, and Two-Spirit peoples. And as we gather together today, I encourage you to reflect on your positionality on these lands and your personal commitments to reconciliation. And I'd also like to acknowledge that last weekend was the 35th Women's Memorial March that was held here in Vancouver to honor the lives of missing and murdered Indigenous women, girls, Two-Spirit, and gender diverse peoples. And I think this offers an opportunity to reflect on the ways that we as a research community aim to honor and meaningfully include the voices of Indigenous peoples and traditional ways of knowing in the work that we carry out so that, all folks can benefit. So with that, I am very pleased to be able to introduce our round speaker for today. Dr. Jessica McAlpine is a surgeon scientist at the University of British Columbia and BC Cancer. She has been appointed the Dr. Chu Wee Memorial Chair in Gynecologic Oncology at the University of BC and at BC Cancer. She is co-division head, tumor bank director, and part of the OVCARE and GCI research teams. Her research focuses on molecular subtypes of endometrial, ovarian, and vulvar cancers and prevention of ovarian cancers. So with that, I am pleased to hand it over to Jessica.
Thanks very, very much, Kath. And thanks to WHRI, who has welcomed me and been good to me since I think the first time I returned to Vancouver. And many of the research that I'll describe today and share are from WHRI research collaborators and team members, for which I'm really grateful to collaborate with. So I'm going to spend the first 10 to 15 minutes of this to really talk about where endometrial cancer has gone in the last decade, how we've come, what is the motivation for change in the research discovery or herein, but also to give a context of how we're going to address the next challenges in this disease site and some of the initiatives that are kind of new and fun because this is a research team and we'd like to share some up and coming data with you. And I do give some educational sessions with financial support, but nothing that impacts this presentation and not talking about off-label drugs. So context of endometrial cancer, this is an incredibly common disease. It is the most common cancer I treat and the most common gynecologic malignancy in most of certainly North America and high-resource nations. It's one of the few cancers that's actually increasing in incidence and mortality. Every year, the statistics demonstrate this, and it's on a trajectory to be second only to breast cancer in the next decade. Most women diagnosed with endometrial cancer are perimenopausal, postmenopausal, but there's about 15 to 20% of individuals, higher, even 30% in Korea and other places, that may be under the age of menopause, maybe not completed their families and wish to, or are not interested in having their ovaries removed with surgical menopause and all the health consequences that go with that. And it's been a little bit appalling how much research attention and funding have gone to endometrial cancer, considering how common it is. Many things that will be familiar to the WHRI that may be challenges with it, and some of it may be also certainly that there has been this sort of assumption that the majority of women with endometrial cancer are diagnosed with disease confined to the uterus and do very well. But it's for that 20% plus of patients that we're not able to identify at a higher risk of recurrence or already have metastatic disease that we do very poorly with and that are where we need to do better. So I'm going to talk about the challenges that motivated some of the change into a new molecular classification system. And one of the main ones is just that a system that worked very well in something like ovarian cancer, which is looking under the microscope or histomorphology or pathology does not work well for endometrial cancer. So when pathologists give a report, they talk about things like grade and histotype, and that is looking at how crowded the glands are, how angry the cells look, et cetera. And again, where in ovarian cancer you might have interobserver variability that is at a minimum, in endometrial cancer, up to a third of high-grade cancers, for example, will have disagreement with leading pathologists or a lack of consensus in a third of the cases. So for an individual patient, that can mean that they are told, for example, they have a high-grade endometrioid cancer and just have 6 weeks of simple vaginal radiation or no treatment, compared to if that same cancer by a different pathologist is reported as a high-grade serous, that might mean 6 months of chemotherapy and radiation. Same patient, clearly one may be missing the mark in overtreatment or undertreatment, and that has been sort of unacceptable variation and what has sort of motivated a lot of this change. So in 2013, a large Cancer Genome Atlas project in endometrial cancers was published. And this is about 500 serous and endometrioid cancers where they did genomic, transcriptomic, proteomic characterization. And very exciting at the time because it identified 4 molecular subgroups, one of which on the left, this polyultramutated, was a novel, at least identified, extremely high mutational burden group with almost no recurrence events. Far right, this copy number high was almost like a basal-like breast cancer, high-grade serous ovarian, and accounting for the majority of recurrences. And then these two intermediate, what was then microsatellite instability high, named hypermutated, now what we think of as mismatch repair deficient, and I'll go into that, and a copy number low intermediate outcome group. And you can see there's there's overlap in certain mutations. There's a high mutational burden to low differences. And all of this was exciting, but not clinically applicable, could not bring it into our VGH pathology or yours at BC Women's, and needed to get something better. So subsequently, two groups, our own and another group in the Netherlands, look to say, could we find surrogate pragmatic tests to replace some of these much more complex, not clinically approved tests, or ones that required normal tissue or very high cost. Eileen Talhook led a lot of this modeling and brought with us this into clinical care by starting initially with 16 different models, settling on one. And then after that discovery set, we did a confirmation separate independent set, and then we validated it in an independent set from Germany, and that allows you to sort of cross-align into clinical application. So this is Institute of Medicine guideline-driven sort of omics legitimate tests. So not any researcher just taking something and trying to implement it into the clinic. So that's the PROMIS algorithm that was generated. And again, just to go over this, because we're going to talk about these molecular subgroups, we couldn't get around having to do sequencing for poly. You need to identify one of 11 pathogenic mutations that's really associated with this very high mutational burden tumor, but that sequencing can be very focused and low cost. Then you have simple immunohistochemistry. Is there presence or absence of some key proteins? One associated sort of step is this mismatch repair deficient proteins. Are they present or absent? If absent, it's a mismatch repair deficient tumor, and the other is for p53 abnormalities, identifying that group with the worst clinical outcomes as shown here. And the ones that have none of those features are so-called no specific molecular profile. So in absence of polymutations, mismatch repair deficiency, or p53 abnormalities. And within 5 years of the first publication of development of this classifier, the World Health Organization had recommended integration into clinical practice, and it's now considered standard of care. So this is just a figure sort of outlining the 4 molecular subgroups, which are prognostic, but again, importantly, talk about biologic differences. And you can see, if you just even pay attention to the middle panel of this histologic distribution, what we had said under the microscope aspects, you can see the diversity, particularly within p53 abnormal tumors, where essentially every molecular histotype, every histotype that a pathologist would call is represented within there. And clearly that's not telling enough of the biologic story, and we need to improve that. So just sort of what are the main take homes? Why do we do this in clinical practice? If I put my clinician hat on, finally, we have reproducibility in diagnosis. So a pathologist will say, I am so much more relieved to be able to categorize tumors and put biologically like tumors together. And so if you imagine you're trying to interpret a clinical trial, or you as a researcher are trying to study something and you have these incredibly diverse tumors, you're not going to come to any sort of conclusions. And what's very exciting is we can actually do that molecular classification from the very first diagnostic specimen. So if you for those who are clinicians, will understand maybe this, but if you're not, as a researcher, an endometrial biopsy is not, putting a needle through other organs to get to tissue. It's actually can be an office procedure where accessing in the same way that you access a pap smear, you can access the endometrial lining, which lies between the two walls of the musculature. There's crampiness, it's uncomfortable certainly, but it can actually obtain that tissue, which immediately is put in formalin. So you have fantastic antigen preservation for your immunohistochemistry, and you have an ability to do DNA extraction and get all of the information. So they not only hear that they have an endometrial cancer diagnosis, but they can also learn about their molecular subtype and what that might mean for them. The prognostic discernment from the molecular classification is continually reassuring. It is either in clinical trials, it's even within something like a given histotype. So these are all grade 3 endometrioid cancers, what a pathologist has called grade 3 endometrioid. But look at the diversity in outcomes. These are survival curves, worst outcome group, no recurrence event group. And clearly the grade 3 endometrioid name is not telling enough. So this prognostic discernment across groups has been very impactful for allowing us to follow people, to treat them where needed, etc. And about that treatment, that's the very new exciting era with this, is that how they're managed from everything to I need to refer this patient to hereditary cancer testing. And we'll talk more about that in a second, because we know they have an increased likelihood of having a familial mutation, or I need to do lymph nodes on them because I know this molecular subtype has a higher rate of lymph node involvement. So they need to come to a cancer center, or specific treatments, even conventional treatments like chemotherapy, for example, being very important in p53 abnormal tumors, or targeted therapy. And we'll give some examples of this. And what's neat is if you look across all of it, if we look at an era before molecular classification, and we look then with a lens, if we had known her molecular subtype, would we have managed them differently? Overarchingly, yes, 10 to 12% would have had more or less treatment. And particularly impactful within that polymutated group, 45% of patients would have had different recommendations, usually because they were overtreated. Now we would offer de-escalated or no treatment. And also 45% of the p53 abnormals that were, it looks like, undertreated when we look back at what care they had. So impactful and important. So good, we're there. We've got it into WHO recommendations, and we have it available. But the last, I guess, 3 to 5 years have really been looking at, from that framework, how can we do better and what are the differences? So I'll share some of the very recent work and then work going forward. So one of the issues is we've got this 4 molecular subtype framework, but we know there's diversity within. And I'll take one major example, this no specific molecular profile group. I've told you it's defined by what it's not. So an absence of polymutations, mismatch repair deficiency, or p53 abnormal. But you can imagine with the diagnosis of exclusion, you have this kind of catch-all group that is very diverse. And to give some examples of that diversity, say there's a 75-year-old patient with a clear cell cancer. Clear cell ovarian cancers can be all molecular subgroups, but the outcomes within an NSMP clear cell are as poor as p53 abnormal. And that is very different than a young patient with a low-grade endometrioid cancer, where there is no question that just because these two people are put in the same molecular subgroup, they should not be managed the same. And NSMP also has these very funny outlier cancers, mesonephric-like, gastric type, these odd histotypes. And even though NSMP was considered an intermediate risk group, what we worried was it's not really intermediate. It's a mix of a lot of patients who do incredibly well that are these sort of typical estrogen-driven patients, perimenopausal, postmenopausal, a little bit heavy perhaps, and does incredibly well. And then the patients that are these outlier ones where we don't always identify. So subsequently, 2023 was a very good year for people diving into NSMP. Our group, as well as a group in the Netherlands, were the first to publish on this. And effectively, we looked at different cohorts, but we approached it the same with the question, what can we use, whether it's pathologic or molecular features, to discern within this NSMP subgroup that would help stratify outcomes? And the Dutch group looked at clinical trial data in higher risk NSMP patients, advanced stage or otherwise. We looked at all comers of NSMP in over 1,500 endometrial cancer patients, but applied the same sort of questions. Is it path features like lymph-vascular space invasion? Is it L1-CAM overexpression, beta-catenin mutations? And both came down to the conclusion that estrogen receptor status was the key parameter. This is just a oncoplot looking at molecular differences between the usual estrogen receptor positive NSMP, about 85% of their cohort, versus the 15% ER negative, and look at the differences. And this can be also expanded out to mutational profiles, IHC features, and pathologic features. And the right, our group looked at the differences that if you were an estrogen receptor strong, positive, low-grade endometrial cancer, your outcomes were fantastic. The risk of disease-specific death, less than 2%. These are candidates for de-escalation, and this is 85% of our NSMP population, so important to identify and hopefully reduce treatment. And in contrast, this ER-negative high-grade group had much higher rates of recurrence and needs to be managed differently. And we've subsequently characterized ER expression a bit further. What's used now very commonly is not just ER positive negative, but something called an all-red score that's also used in breast cancer. Some of you may be familiar with, but it's a combination of percentage of cells that are staining as well as intensity, et cetera. And most NSMP are strong, all red, 7, 8 strong ER positive, but you can get ER negatives and these intermediates that have worse outcomes, often flagging some of those rare subtypes I mentioned. So pathologically important to do additional tests, but even within endometrioid do worse. And this from the first 2023 publications and characterization is now part of 2025 ESCO guidelines, where ER is a major stratification feature and ER negative NSMP are considered high risk along with P53 abnormal. The challenge being that they've said that, but how to treat it, we treat it like P53 abnormal according to them, but they're biologically different and much more work needs to be done to find the best treatments for these patients, but important to identify it. So this is sort of become the official fifth molecular subtype where ER stratifies NSMP. This is an example of a low-grade endometrial cancer with ER staining essentially all of the glandular cells. And so a very important discernment. And we don't think ER stratification is important in the other molecular subtypes, but it's often given. And so, coming along with these research discoveries have been clinical implementation of these tests, just showing again from knowing a mismatch repair was important, implementation in guidelines. It took us a while to partner with a local company to get POLI testing available first on clinical trial patients, now for all patients free, P53 added, and ER has been done here since 2023, even though the guidelines internationally took a year or two to catch up. And this is relevant just for the researchers in the room. This actually changes clinical practice. So our BC Cancer guidelines say to patients who are managed in their outside community, so someone's in Vernon, gets diagnosed, they would have in their local center, we say, do immunohistochemistry for mismatch repair, P53 and ER. They'll wait on the NGS or the next generation sequencing for for later, or they can send it to Vancouver reflexively. But even these proteins will help direct who is managed in their community versus coming to a tertiary cancer center, because we know that certain molecular subtypes, for example, within this mismatch repair deficient or P53 abnormal, higher risk of lymph node positivity. So we want to do lymph nodes here in Vancouver versus someone who's very low-grade indolent and lymph node dissection does not impact their outcomes, could be managed in their home community, saving travel and stress and otherwise. Another example of stratification I'm going to talk about that is new, kind of hot off the press aspects, but have been, I guess, suspected and considered for a few years in early development, has been stratification of the other intermediate risk subgroup, mismatch repair deficient. So mismatch repair deficient tumors can actually arise by a couple of different ways. So remembering this is another type of DNA repair. It can come from a germline mutation in one of the mismatch repair proteins, of which there's actually multiple, but 4 that are the most common are what are tested, often 2 because they form little buddy systems or dimers together with MLH1 and PMS2 being co-expressed, as well as MSH2 and MSH6. So you can do immunohistochemistry, but the largest category of mismatch repair deficient tumors is actually those with epigenetic silencing. So you get a promoter hypermethylation of MLH1 that renders it dysfunctional, so you get mismatch repair deficiency by that mechanism. And those two groups have thought to be different for some time. So obviously it's important because an MLH1 hypermethylated tumor is not needed to be tested for germline. It's not a germline associated event, but testing those others is incredibly important, both to identify for that patient so she can screen for other tumors that are associated with Lynch syndrome, such as colorectal cancers, but also for family members and cascade testing and for other risk-reducing interventions. So hugely important, with endometrial cancer being this sort of sentinel cancer or first detected in families in a lot of women. Really important for predictive implications. Immune checkpoint inhibitors are this really exciting category of drugs where you have this high hypermutated cancer. Tons of mutations means tons of neoantigens, a big turn on of the immune signal. That is usually checked at a certain point and sort of tempered, and you can reverse that through checkpoint blockade. And there's been several very important studies showing that immune checkpoint with chemotherapy has this dramatic improvement from placebo versus one of the immune checkpoint inhibitors in a couple of big landmark trials. Hazard ratio is 0.3 with taking that drug, and so been a real game changer. But also recently, and just published last month, this work led by Amy and our team, this substratification of mismatch repair is really important for prognostic reasons. And the MLH1 loss tumors have far inferior outcomes. They are more likely to have poor tumor infiltrating lymphocytes. They are probably the ones that are least likely to respond to immune checkpoint, although the majority of these trials had MLH1 hypermethylated tumors, and they overall still do get response. So we still treat patients with this. But when you're thinking about substratifying for treatment selection, this is going to be important. And when you're thinking about how you're managing these patients, this is going to be important. So sort of this is the early new kind of news on the 6 molecular substratification of these tumors, and nice to have gotten a little bit further with how we manage these. So the other way we were trying to say this, how can we understand and substratify within subtypes in parallel with this molecular work, was through artificial intelligence. And I'll share some of that work from our team, which we're really excited about. So yeah, we've talked about microscopic, then we went to protein markers and NGS, and could AI stratify further? And so I think folks are familiar that when you have tumor block or tumor removed from a patient, it gets put into wax and cut onto a slide for pathologists to look at. And that H&E image, pathologists look at thousands of them, but they may be hard pressed to remember the case they saw yesterday. And sort of volume that you can do with artificial intelligence is incredible. This is one of the digital scanners, for example, that can take 81 slides at 40x magnification every hour. So that's like 2 to 5 GB of data, 100,000 by 100,000 pixels to go deep, if you will, and to interpret things. So I'll run through that slightly. This is work Dr. Bashashadi led, and we published in 2024. Um, we tried to look at it within an NSMP to look at features that would be different, things that we weren't seeing by pathology imaging, things that we weren't picking up by um, molecular features as well. So, two ways to get a tissue specimen. Imagine a hysterectomy with one of our surgical teams, or we're actually have this working now on endometrial biopsy, which we're really excited about. So you get tissue, it gets onto a slide, and there's a whole bunch of control, if you can imagine, because you, particularly with biopsies, you might have blood, inflammatory, exudate, other things that have to get cleaned off. And also the way that the slide is stained in Vancouver might be a little bit different than the slide that's stained in Victoria. So you have this sort of colorimetric correction as well. And these images are pixelated. I talked about the depth of pixelation before, and then passed into this convoluted neural network that is able to break down and on, have to have training sets of maybe thousands of cases initially, that then can be validated in smaller numbers, but identify effectively two different subgroups. This excellent outcome NSMP and this inferior outcome group that we've termed P53 abnormal like NSMP because their outcomes are close to that P53 abnormal. So these were some figures from the Nature Communication paper. These are the excellent outcome NSMPs. In orange is this high risk or P53 abnormal like NSMP, and these are regular P53 abnormals that were indiscernible. What's also neat is if you look at the in-depth profiles of these P53 abnormal like NSMPs, they are also different. They have copy number alterations that are much more similar to P53 abnormal like. And that was a feature, remember, in the Cancer Genome Atlas as well. Copy number analysis isn't something you can do at in a clinical lab and is again expensive, requires normal, and it requires a bit more aspects. And this AI is almost serving as a sort of surrogate to identify this group, but again, just suggesting that these are very different tumors and worth sort of discerning with that. And these are our biopsy work. So Miriam is going to present this at USCAP next month, but it appears to work in endometrial biopsy, and we've done this in a training set and a validation set. And that's key for us because that would allow us to direct and triage patients much earlier in their cancer journeys and to understand where they need to be managed. Is that all very pie in the sky and we're never going to be able to use any of this AI thing? It's not. So Canada has huge geographic distances, and we're quite used to this, as are my colleagues in Scandinavia and otherwise, where, for example, say you have a very tricky pathology diagnosis case, you can, with a digital scanner, scan the images to your friend in, New York or Vancouver and say, hey, what do you think of this tumor? And that concept of digital scanning helps us open this up. So, for example, we're trying to look for this discernment from an AI screen to differentiate P53 abnormal like versus the rest. We'll walk through a patient case to this, but through a cloud-based system, which we're in a pilot this year, you have the ability to take that scan system, interpret it with the appropriate software, and come out with an answer. So let's take an example too. We say it's a patient from up north. This is a teacher from Prince George. She's had all the right workup in terms of an examination, and it seems like it's uterine confined disease by that. She's had molecular testing done, and had her pathology report done. And the molecular testing shows that it's an estrogen receptor strong positive, mismatch repair proficient, P53 normal or wild type. And the path then would be sent down to Vancouver, both for the NGS testing if it was indicated, but also has this opportunity to either do the H&E slide locally and scan it down, or when the tumor blocks in Vancouver, have it scanned. And when it's scanned and processed through this cloud-based system or otherwise, as she's actually identified to have this P53 abnormal like higher risk, not seen by molecular testing, not seen by path. And we say, actually, you need to come down to Vancouver or to go to Kelowna or Victoria, one of the cancer centers that has the ability to do lymph node dissection. And then we want to test your tumor to also direct the most appropriate adjuvant treatment. So again, we'll be piloting and looking at that. And I'm not going to go through all of the AI initiatives that we're doing, but there's some exciting ones. So I talked about how copy number analysis was hinted at with this. It's not a specific, but you can imagine that again, AI can be used as a surrogate for certain tests. The prognostic discernment, we gave one example, and I haven't shown you examples in mismatch repair deficient tumors, but like that substratification by molecular features, can AI identify the worst outcome groups, and are those the MLH1 loss, very different mismatch repair deficient tumors? There's really neat things happening in the predictive space. So a paper under final review of Dr. Bashashadi and many of the MedOnc team in our group as well, looking at PARP inhibitor response. So one of the most exciting treatments in ovarian cancer, initially trained relating to platinum sensitivity, but then tested to look for PARP inhibitor response. PARP inhibitor testing, things like trying to understand who would be the best candidates for that treatment has been very complex on the clinical side. And so this surrogate test would be very exciting. So what's another example? I'd say this has been an exciting branch in the last 2 to 3 years about different patient factors and understanding and stratifying endometrial cancer further. So coming into this, what did we know? We knew that from data largely populated from US statistics that there were some of the most marked examples of disparities in endometrial cancer than any other solid tumor. And everything from how a patient is worked up to treated to ability to participate in clinical trials is markedly discordant. The outcomes of Black patients in the US statistics are at least twofold worse in terms of mortality, and within the particularly P53 abnormal enrichment and the non-endometrioid subtypes, even higher, and for Asian women as well. So, and it's also increasing at a much higher rate, which we don't fully understand. So a lot of the US data is aggregated, and we wanted to look at this in our own statistics, and there has been a practice where actually no self-reported ethnicity data makes most of the clinical charting in Vancouver until very recently, or across British Columbia until very recently, and indeed is not available in the rest of Canada uniformly either, aside of hereditary cancer programs. So we talked with our ethics boards and our regulatory boards, and that again came from a real history of systemic racism, but was not actually precluded from any other good reasons, and realizing that these important data were not being considered, and that it was potentially missing an opportunity to improve these disparities and to address genomic differences that could be targeted and to get better outcomes. So we went about implementing it in 2023 so that all newly diagnosed and gynecologic cancer patients were asked to self-identify in terms of ethnicity. That went into our tumor bank, and then we actually went back to 2003 because there's one paper form that was in the charts that was not collected in any electronic data or in notes, but was in the paper chart that had self-reported ethnicity. So we were able to populate right now over 1,000 patients with endometrial cancer in British Columbia. Shown in the left here are the proportions of endometrial cancers across self-reported ethnicities as compared to BC Census. We are slightly enriched with more urban center patients. So I think some of the discordances are explained by that. For example, the differences in Indigenous populations. But what was very interesting, what we were interested in too, is what is the difference between the molecular subtype distribution in these patients? And because most of the data previously has been based on North European white descent patients. So this is just some examples. The four molecular subtypes and their colors are as shown, and there are differences, and some of that we're teasing out, but important for hereditary syndromes, important for targeted treatment, important for screening and otherwise. Another example of a patient factor that is kind of new and hot off the press we're excited about, Kath Gray, one of your residents, is working on this, is, polymutated subgroup. I haven't spent a lot of time talking about. This is the big win group for endometrial cancer for us. These are called sheep's and wolf clothing. They often look under the microscope very aggressive. They were high grade. In about a third of the cases, they might have lymphovascular space invasion. They're usually confined to the uterus, but still they look ugly. So these are one of the ones I had described as being often overtreated in the past. So we now de-escalate most of these patients. But what we're learning or seeing is that with more routine lymph node dissection, with more routine NGS, we're finding more of these advanced stage polymutated cases. And some of them are not your usual immune-rich tumors. So we've had several solid organ transplant patients, for example, where have very extensive disease and very rapid recurrence, patients with lupus, immunosuppressed for other reasons. And so, here's an example of a typical polymutated cancer with huge number of intraepithelial lymphocytes as well as peritumoral, inflammatory reaction in lymphocytes as compared to the sort of paucity within this organ transplant patient on the right. And so this is an area of great interest, and it may be, of course, that very different strategies are needed for patients in this situation. Very quickly on targeted treatment opportunities, the group that we do the worst with is P53 abnormal subgroup, responsible for majority of deaths. We've looked to characterize these through shallow whole genome sequencing and targeted mutational panels. These are work from Dawn Cochran and Juliana and Amy as well. And we looked at, what are the differences and what would be targetable within these P53 abnormal. We know they need chemotherapy. We know they need good surgery, but what else could we do? And you do unveil targets. Interestingly, quite a lot of overlap of features, but about a third over will have overexpression of HER2, for example. That's targetable. We know about that from breast cancer, from single agents, but also this new category of antibody drug conjugates, where you have a chemotherapy payload linked to something that targets a given antigen feature in a tumor, and those can be very effective. Homologous recombination deficiency, a big category within ovarian cancer, lots more work to do in endometrial, targetable mutations through different drug trials. So, promise. And this is just some of the examples in endometrial cancer that we're excited about, where again, they're either this antibody drug conjugate aspect or aspects like we talked about immune checkpoint in mismatch repair deficient immune rich tumors, but there's also subsets of endometrial cancer you wouldn't think of as immune rich that can potentially be good targets. So Spence Martin and Alan Zhang from our team have published on this, and we look at options within P53 abnormal as well. So we're getting there. And then I think finally, I'll just share that one of the new initiatives we're trying to do is say, could we actually target things earlier? We know that there's patients at risk for developing endometrial cancer that may be from an inherited syndrome like Lynch syndrome, that may be just based on their body habitus, right? Or you could say just getting older puts you at risk. So could you screen and do things? And we haven't traditionally done molecular classification on precursor lesions, atypical endometrial hyperplasia, but we're learning that if you do, those features are there. Most precursor lesions or early ECs are that no specific molecular profile, but you do get some that are mismatch repair deficient, as in this patient, where she was savvy and asked if I would do it, and we did, and indeed she had MLH1 and PMS2 loss. So we're excited about that work. Happy to answer any questions on it, but I think I will wrap and open things up. And I think, just in summary, I think we feel very good about where we are. And certainly as a clinician, given the deficiencies of a decade ago, we're in a much better place, but I think we still can do better. We do have reproducible diagnosis now. We have prognostic information. We can do it on biopsies. It can impact our treatments. And we're not just talking about it, we've implemented those changes for the patients in front of us, which is exciting. But yeah, with this multidisciplinary team we all work with, we look forward to doing better and certainly sharing this research on behalf of a big team, and happy to open it up for questions.
That's great. Thanks, Jess. Anybody have any questions? If you don't want to raise your hand or unmute yourself, you can just pop it in the chat and I'll be happy to read it out. Maybe I can just start off by asking a potentially silly question. But I was really intrigued by your AI work, and I think a lot of AI learns on the kind of set of information that you put into it. Is there any initiatives going on to kind of have more of an international library of these types of data, so that I'm just wondering if some things are a bit population specific?
Yeah, yeah, hugely good questions. And there's so many applications of AI. Um, I don't know if, I mean, I can tell you Dr. Bhattacharya collaborates with a ton of people, and obviously all the data I showed you was from multiple sites. So using cases and then putting data entry in. Um, I can tell you other teams have also looked at it in endometrial cancer for triage, more of a, hey, how does it align with the traditional risk groups? And we're trying to develop systems in clinical care where you as a patient are trying to come into the cancer center, and we're trying to take not just piecemeal aspects, but to have an integrated aspect of your CAT scan, your MRI, your scanned pathology report, your patient factors that I talked about, your health and otherwise, and it would assist to triage at a level of urgency. And that's being piloted with the breast cancer team at St. Paul's. And we're working with the UBC AI person for that. But your point is a good one. Like, could all of these data on histopathology, imaging, and every little squirrel hunt from AI be in some data repository where it all came together? I mean, we're excited about that. And I think one of the things we're really excited about too is this idea that it seems crazy because you're only got a few patients in certain subsets, but we're training on it. For example, Andrea Nielsen's doing some work on progesterone response in precancers and early cancers. And we will look at those in the framework of patient factors and molecular features, but we want AI to also look and could that scan and do it. And then that's rare-ish. It's hard to get those cases. So those should be shared because there's other clinical trials in Italy and one that just wrapped up in Australia, and you wish you could get all of their images, which we're asking them for. And so hopefully they'll provide it.
It's really exciting. I see Nicole has popped a question in to the chat. So she thanks you for a great presentation. And she asks, can you speak to your experience or strategies or lessons learned getting this science implemented within the health system and guidelines like WHO?
Yeah, no, gosh, Nicole's been so helpful for our team with that. Clinicians need more training and knowledge translation and implementation for all of the researchers out there to take whatever courses and go to whatever sessions you can. I mean, I think you start to realize who you're working with and how lucky you are with if you have a team that collaborates well and has some mutual respect and is willing to listen as well as just tell. And we've had that in British Columbia for a couple of reasons. I think before I get to WHO, I would say that British Columbia, whether it's opportunistic self-injectomy or molecular classification, has this great relationship with the provincial gynecologists and family practitioners for, I think, because we pick up the phone all the time about questions and have a yearly meeting and stuff. But yeah, that you're not, we had some engagement about the molecular classification tool, for example, with British Columbia gynecologists. How do you see this working for you? What would you see the barriers are? And how can we help with that? And some of those are tough. There people are remote or their facility says they don't want to do it. Um, but one of the main reasons that that's been successful is, I think, having multidisciplinary teams. So pathologists who are leaders in their field, who people listen to, who say, I think it's empowering too. Like, you can do this in your center. Don't just send to the mothership. You guys can do this. Let's train everyone to a level and do it. And that has been wildly successful. I think I wish I knew more policymakers and that aspect, but we did apply for money to get free testing, for example. So even though we didn't know the person who could open the purse, we did know and learn of a system where we could ask for that. So I think I think it's three pronged. So for example, for the other group, for others in the group, the pathologist would have me come to the path meetings and say why, as a clinician, I needed it. And then I would have him come to the clinical meetings to say, hey, this is what this means, and this is what I can give you, and this is why it's important, and that was good. And then I guess leadership or engagement, I think many of us do a lot of international things, so that helped, and sharing so that your data become international, and then an international organization will say, yeah, I see that too, and let's implement that. But it's getting faster, I think, if anything. Like the ER took 2 years to less than 2 years to get into change.
Cool. Any other questions from the group? All right. Well, if not, I would just like to thank you, Jess, for an amazing presentation. This is such an incredible body of work, and it's been so great hearing about it. So I guess if anybody thinks of any last minute questions, you can send them to me and perhaps I'll gather them up. But just love to just want to thank you for sharing with us today. It's been great.
Yeah, no, thanks to the larger team and lots of great folks at WHR and GCI. So thank you. Cheers.
Thanks, everybody. Have a great weekend.
Thanks.
Bye.